Hi, everyone. Thanks for joining us today for our fourth and final webinar in our four-part series. I'm Joe Young, CEO of Global Data Systems, and I want to thank those of you who are attending today and to those who have joined us for all four parts of the series. We understand how difficult it is to be able to carve out any extra time out of your day, and we appreciate you making the extra effort to attend. So with us, as always, is Jen Monahan, partner at Health One Technologies. She is our subject matter expert on all things healthcare. And today she's going to finish the series by providing a deep dive on the clinical improvement activities, including requirements, scoring, and how to start the process. So a quick recap of the first three parts. We did an overview of the macro MIPS program. We then provided deep dive information on the quality measures, and then we also provided a deep dive on the ACI measures. And because today we're recording this webinar, and we've also recorded the other three, you can go back anytime and review the information we've provided. You'll all be sent links to today's, and if you've registered for the past events, you will have received links so you can go and take a listen to these whenever you want to. And of course, you can always get in touch with either me or Jen, and we can answer any questions you have. And lastly, I also want to point out that at any time during the presentation, you can submit your questions by typing them in the chat section there on the control panel, and we'll get to them at the end of the presentation. So without any further delay, here's Jen.
Thanks, Joe, for the introduction. Welcome, everybody. Today, as Joe said, we are going to dive into the clinical improvement activities, and this is the final component of the MIPS program for 2017. So what we're going to talk about today with the clinical improvement activities is an overview, just kind of what the program looks like, what the requirements are, what the exceptions and alternatives, individual and group reporting, submission methods, scoring, and then how to start the process. And lastly, at the end of this, I'm going to do a webinar recap, basically, of what we have done in the past. Clinical improvement activities is a brand new component. So previously, if you guys have attended the other webinars, the quality is very similar to PQRS, and the advancing care information is very similar to meaningful use. Clinical improvement activities, however, is a brand new component. It's something that we don't have a lot of experience with in the industry. It's going to represent 15% of our score, and I think the reason that they did that is because it is a brand new component. This particular area focuses on, CMS has kind of defined what they want to do with clinical improvement activities. And there's a couple of key areas that the measures are focused around. And I've bulleted those out on the screen. I'm just going to kind of quickly go through them and mention what they are. Achieving health equity. This is basically closing the gap between poor and different classes of healthcare that are delivered out there. And beneficiary engagement, engaging our patients in what we do. Care coordination is coordinating care so that we're working with specialists and other people that might be involved in the care of the patient. Emergency response and preparedness, healthcare delivery, which is just how we're overall delivering it. Does the patient have to come to the office, or can we use some telehealth or things like that? A focus on integrated behavioral and mental health. This is certainly something that the industry is focusing on. Patient safety and practice, and then population management as a whole. So that is what the purpose of clinical improvement activities are. There's a lot of discussion in the final rule about how their belief is that these areas will ultimately, if we focus on these areas, it will ultimately increase the overall quality of care that we are providing with our patients. The ones you see listed here are baselines. So these are the baseline sort of components or areas that we're focusing on. They're sort of not necessarily stringent. for this year. You'll see that they're kind of fluid in how we interpret them and what we do. And then I envision that in the future years that this will actually get tightened up a little bit as they have more exposure to it. One thing I did want to point out is that these activities were developed by CMS with a wide representation of stakeholders. And by stakeholders, I mean the people that basically were involved in what topics they focused on, and then within the topics, what they pulled out as the various activities they felt were most important. It included physician practices and people that make, the actual laws, and hospitals and insurance payers. Like, there were lots of different people involved in the process of selecting these. The requirements for clinical improvement activities are very similar to what you've seen with the other components as well. So 2017, again, is a transition period, so everything is a 90-day requirement. CMS is encouraging a full year of reporting, as with the other ones, and if we are doing a full year, if your choice is to do a full year of reporting, we would engage in these activities for that full year. Each clinician or group needs a total of 40 points to receive the full credit. So that's basically the maximum that you can get, are 40 points. And the activities are broken into two categories, high and medium. If you choose a high priority activity, you get 20 points for each activity. And if you choose a medium priority, you get 10 points for each activity. There are several exceptions and alternatives to the point system. Points are doubled if you fall into certain criteria. So if you're a small practice and you have less than 15 physicians, or actually that should be eligible clinicians, not physicians, in your practice. If you're a rural practice, and this is based on a zip code, some of you that had done meaningful use may have actually been aware of this. There was a bonus if you were in a rural area when you were doing meaningful use. There's a website that you can go type in your zip code, and it'll tell you if you actually fall into that category or not. Health professional shortage areas, and that's a certain act that's out there. There's, again, a website that you would know if you fell into the health professional shortage area. And then non-patient facing clinicians. And I think we covered that previously about the people like radiologists and pathologists, and the folks that just aren't necessarily in front of the patient a lot will have the same doubling of the points. What will happen for this particular group of people is that if you have a high priority measure, you're going to get 40 points instead of the 20 points that everybody else did. And if you choose a medium priority, you'll get 20 instead of 10. So basically your points are just doubled. Another exception is that if you are currently participating in a patient-centered medical home, I know that this is mostly a primary care initiative. However, CMS has sort of expanded the definition of a patient-centered medical home. They've listed a few requirements if it's a national recognized program, if it's a program that's across the nation, for instance, and it may be a specialty program, but if there's something that is like PCMH, they may consider that in this process. If you are participating in PCMH or a PCMS-like program, you get the 40 points automatically. So you don't have to do any of the extra improvement activities that are listed here. You'll just have to claim that you are participating in the PCMH, and then you'll actually get the full credit for this particular program. Another alternative to this, which was pretty interesting, is because this is a brand new component and something that nobody's really familiar with in the industry, CMS is doing a study on the impact of clinical improvement activities to the outcomes that we see. So if you participate in this study, you'll actually get the full 40 points. There's a limited registration. They have a certain key number of types of practices and groups that they're looking for. There's a deadline to register as well. And then, this is just overall, in my thought, a great opportunity to provide direct feedback to CMS. So basically, the study would involve you working directly with CMS in how these measures are impacting both your practice and your patients, and potentially have the ability to influence the future program. So this is just something I had found I thought people might be interested in. If you're wanting that and want to know the deadlines and such, you can just reach out to us later and I can get that for you. As in our other programs, we can report as individuals or groups. Again, you're going to want to make this decision as your organization as a whole, because whatever you choose, you're going to have to do for all three components. So if you're going to do as an individual, you're going to do that for quality, ACI, and clinical improvement activities. And then if you're going to choose the group, you would do the same thing. If you choose individual reporting, whether it's for this or the other two that we had done previously, each clinician gets their own activities and they're scored on an individual basis. The payment adjustments are done on an individual basis. Providers could have different activities if they wanted, or you could standardize it across the practice. The payment adjustments is based on the performance, so kind of allows if there's physicians that are really wanting to get into the program, they can do a really, really good job of it, and their payments are adjusted just based on their performance alone. And the downside to the individual reporting is your administrative burden may be a little bit higher because you're running reports and providing focus and potentially measures for each individual physician. Group reporting, so the score is submitted for the group, regardless of your specialty, regardless of anything. So when we do this, the group submits, and that is what is sent to CMS for the final calculation of your score. The activities would be standard across the organization, typically a lower administrative burden because you're having one set of measures, one set of focus that you're doing. And the one con to this is that the high-performing providers might be impacted by the lower-performing providers. There are different ways, very similar to the other components that we have discussed previously as well, but different ways to submit clinical improvement activities. And one thing that I thought was important here is there is no way for us to do claim submission for these, so that's just something I wanted to make everybody aware of. You will use your QCDR, your clinical data registry, or a certified registry. And there may be some sort of attestation that wasn't clearly defined in the actual final rule, but it did say that there would be some attestation mechanism available, and then also the CMS web interface. When we're scoring the clinical improvement activities, I felt this was the simplest of the three components. Quality and ACI were a little complicated when it came to scoring. I think the improvement activities are pretty straightforward. Each activity, you're basically going to say, yes, I did it, or no, I did not, whenever you're doing the reporting. It does, one thing I wanted to point out, the yes does have to be done for the entire reporting period that you're doing. So if you're doing something for 90 days, then the assumption is that you're completing this activity for that entire time period. So again, the most score that you can get is 40 points. That's the highest that you can get out of this system. So every high priority measure that you do, that you say yes to, you're going to get 20 points. And every medium priority, you're going to get 10 points. And then basically your score gets totaled. If you report nothing, you're going to get a 0. Your total score is calculated at 15%. That's the weighted percent of this score to your total MIP score. I just broke a few examples for us to look at here. So we have a larger multi-specialty group, and I'm assuming that they're reporting as a group. They're going to choose a high priority activity. I just used an example here, engagement of new Medicaid patients and follow-up. So they're going to get 20 points for that. And then a medium priority, engagement of patients, family, and caregivers in developing a plan of care. So they're going to get 10 points for that. They do no other activities. There's a lot for them to manage. It's a lot to take on. So they have 30 points total for their clinical improvement score. So they got 20 for the high priority, 10 for the medium, so they have 30 out of 40 is their score. That 30 points is taken times 15%, because that's the weighted score of the improvement activities, and the 4.5 points gets added to your total MIP score. Another example, I did this one because this is a representation of a smaller practice, so it's a 3-doctor practice. So we'd assume they have 15 or less eligible clinicians, and their points are doubled. So I had them choose a high priority activity of anticoagulation management, and they're going to get 40 points for that because it's a high priority, double score, so that's all they have to do. They do no other activities. They get the full 40 points at that point. Take the 40 points times the 15%, and you get 6 points that will be added to your total MIP score. Just a few other key items that I thought were important. CMS originally had this measure set at 60 points and extra measures that were attached to it. That has actually been decreased in the final ruling. Again, in the future, though, I do think that this will become more of something that we see and we have to incorporate into our system. So I just want to make sure everybody is aware that this is something I wouldn't ignore. I wouldn't just say it's only 6 points, I'm going to take a 0 for it. I think I would definitely start working on figuring out how to incorporate this into our practices. Again, not reporting gets you a 0. So those 6 points actually add up if you do them all. Every little bit counts. If you don't do anything, you're going to get 0 added. There are also bonus points that go back to the ACI component. So there are certain improvement activities that are linked to using your EHR technology, and when you look up the measures, you'll actually see that there's a column that says this is related to your EHR. And if that's the case, there are bonus points available on your ACI component, not on your improvement activities. So that's just something to keep in mind when you're selecting activities. You might want to do something that uses your EHR technology because you could potentially get some bonus points. One other thing, if you are deciding to report as a group, I had a few questions and discussions about this as far as, does the entire group have to be doing the activity, or can it be one location, or how does CMS look at that? And I pulled this actual paragraph out of the final rule because it's pretty clear. It's explained very nicely here. Basically, it says that we'd like to explain that each eligible clinician reporting as a group receives the same score for improvement activities. So if at least one clinician within the group is performing the activities for a continuous 90 days, then the group may report on that activity. So I think that's an important element to know if you're reporting as a group and you're looking at the clinical improvement activities. If you have a large organization, multi-specialty group, you may just want to focus on one particular location or one provider that you can kind of do these activities with, get it going, make sure it's working, and then you can get it out to your other groups. You will get credit for that under this component. So now that kind of reviewed the activities and how they're scored, what do we do? So again, if you don't do anything, you get a 0. The measures are available on the QPP website. That's the same website that I have passed out for the other components as well. The one thing with this, which is very similar to your ACI measures as well, is I really think we can leverage the use of our EHR. A lot of you have already put a lot of effort and focus into using your systems and implementing your systems, and I think it's a time that we can really get information out. Also a time to consider an optimization of your EHR in conjunction with MIP. A lot of people haven't done any sort of review or changes to their system since they've been implemented. And if some of you have been participating in Meaningful Use when it started, that was in 2011. So many years have passed since we've been doing this, and if you haven't really done a deep dive into your system and your workflows and just talking to your staff about how they're using the system, you may not be getting the most out of it. So I think this is a time to consider doing some optimization of your system in conjunction with a program like this, because it really does give you a holistic approach to your practice and the technology that you're using. The other thing is to involve clinical staff and providers. These activities are going to definitely involve providers and staff, and we want to make sure that we have a good clinical input as we're going through the process. So once you know the activities that you're going to select, you need to just really kind of dive into that and understand what the activity is asking for, and then how you're going to capture that and improve your process. Update your technology. Again, it's a time for taking a look at what you can do with your systems. If you need to put something in place, might be a new report that allows you to capture patients, certain class of patients that you need to, because you need to reach out to them. It just might be a time to really kind of look and see what your system can do for you instead of you just clicking all the data into it. Adjust your clinical administrative workflows. That's going to be an important step of this. And then keep good records, because I don't know what the audit process is going to look like for this in the future. I would assume it's going to be similar to meaningful use, and since these are all attestations, I would make sure that you keep any records that you have going through the process. So if you develop a workflow, make sure that workflow is documented. If you have system changes that you've done or anything like that, just make sure that you have all of that documented and in place if there is an audit in the future. So I'm just going to do a quick recap of the program as a whole from where we started several weeks ago. Overview is just a few key dates. January 1st we start. That's coming up rather quickly on us. You have the full year, and again, if you don't start by January 1st, it doesn't mean that you can't do a full year participation still. We have ways of going back and entering data and doing things like that. So if you haven't started, don't panic. We can still start going even into January if you choose to do a full year of reporting. The deadline for data submission is going to be March 31st, so we have some time for that yet. And payment adjustments will begin on January 1st of 2019. Eligible clinicians for 2017, again, physicians, PAs, nurse practitioners, clinical nurse specialists, and CRNAs. So that's all that are available for 2017. And this information is on our first webinar, the overview of the macro program. So if you guys are going to go take a look at that, that's where you'd want to find more detailed information about this. First thing that you're going to need to do, and the reason I put this slide in here, is to pick your pace. You know, how are you going to want to submit? You want to just avoid a penalty. You want to try to get some incentive dollars. You want to try to go after a lot of incentive dollars. And that's really kind of the first step in the program, is understanding how you want to participate. So I think that is an important recap item that we needed to discuss. And then again, just a pie chart. I think everybody's probably tired of seeing this pie chart at this point, but this is a representation of how the categories are broken up. So your total MIP score from 0 to 100 is based on these three categories, and it's weighted based on how you see it in the pie chart. So quality is 60%, advancing care is 25%, and improvement activities are 15%. Quality measure recap. So again, this takes place, this is the PQRS system, basically. What we did in the past represents 60% of your score. For the most part, eligible clinicians are going to select 6 measures. 1 must be an outcome measure. If there's not an outcome measure, then you choose a high priority measure. No cross-cutting measures are required for 2017, and we don't have to cross multiple domains. Every measure has a score from 0 to 10. Depending on your performance, that score might get more, might get less. Every measure that you report on is going to get you a minimum of 3 points. So if you report one measure, you have 3 points under the quality program. If you don't report anything, you get a 0. And again, if you want to see that in more detail, that's on our second webinar, Deep Dive into the Quality Measures and Myths. Advancing care information. So this is basically meaningful use in the past and represents 25% of your score. There are 2 measure selections options available depending on your certification version. As I said in my webinar, most of you are going to be on the 2014 certified version, which means that you're going to select the 2017 transition measures for that. 90-day reporting period required for 2017. And the way the measures are for ACI is they're broken into base measures, which are required to get 50%. And then there are additional measures that make up your performance, which is another 50% of your score. And then there are bonus points available as well. All of that is covered in webinar number 3, a deep dive into the advancing care information. And then just a quick recap of what we talked about today with the clinical improvement activities. Brand new component equals 15% of your score. We need to do a 90-day attestation. To get full credit, you need 40 points. The high priority measures are 20. The medium priority measures are 10. Points are doubled. So if you're a small practice, rural practice, healthcare shortage, health professional shortage, or non-patient facing clinician, you get double points. If you report nothing, you get a 0. And just one last thing is just pulling this all together to your final score. So again, every eligible clinician or group gets a score from 0 to 100. The score is based on the 3 components of quality, advancing care, and clinical improvement activities. So we combine all those together and you get your total score. A score of 3 points avoids a penalty in 2017. I think that's an important thing to know. If you're just trying to avoid a penalty, we don't have to do a whole lot. If you score higher than a 70, you're actually eligible to receive the highest level of bonus money, which is the exceptional performance bonus money. So not only will you get base incentive dollars, but you'll also get exceptional performance money. Okay, so that wraps up our webinar series for MIPS. Hopefully this has done a good job of giving you guys an overview of the program as a whole, and you have some information to start making good decisions about how you want to participate.
Thanks, Jen.
Open it up for questions.
Yeah, sorry for interrupting you there. We do have one question. When do you think we will get our 2017 final score?
That's a good question. Yeah, in reading the final rule, they've been very gray about that. So what happens, just for those of you that may not understand where this is going to go, but CMS is supposed to release each person's final score sometime in 2018 is the goal. And then the purpose is that you'll be able to take that score and work toward a better score in the next year. So that's kind of the reasoning behind it. I would envision, since we don't have to have our submissions in until March, the end of March, I'm going to make some assumptions here that we are not going to see these scores until well into October, November of 2018. That's really what I kind of think is going to happen. It may get better in future years, but I think as this is the first year of participation and knowing CMS patterns, I think it's probably going to be later in the year before we see this. Maybe they will pleasantly surprise us and we'll get it earlier in the year, but I think it's probably going to be later into the fourth quarter of 2018.
Okay. Right now there's no other questions, so I just want to take the time to thank everyone again for attending. We hope we've given you some valuable content that you can take back to your practice and begin this journey. Wanted to also thank Jen Monahan. Jen, thank you very much. You provided so much information for everyone here. It's a little overwhelming actually, but as we've, you know, up on the screen, please feel free to contact either one of us. Again, we'll send the links to this webinar, but if you miss any of the emails we've sent over the past couple of weeks in terms of the links, feel free to go to our YouTube channel, Global Data Systems, Inc. And Jen, I'm sure Health One has a YouTube channel too. Would you like to share that?
Yeah, I would if I knew what it was. You could just go to our website at h1tech.com. I'm sure we can find a link from there.
Okay. Well, again, thanks everybody. This concludes our series, and good luck with your effort in this process. And reach out to us if you have any questions. Thanks again.
Great. Thank you, guys. Bye.